Sure. Yeah, you have it up.
Whenever you're ready.
Okay. I didn't know if you were, it's not on the screen. I can't see it. I mean, I can see it on my laptop, but as far as the meeting screen, is that something that you can share or?
Let me try again.
Sorry, I'm not sure how that gets put on the screen there.
Is that working?
Can other people see it? It's just a black screen for me, but just so other people can follow along.
I can see part of it. It's just really big on my. Oh, that's better.
Okay.
Okay. All right, great. So the patient that I'm presenting today, I've just seen him, an 11-year-old boy, just once the initial time. So I'm still trying to gather all the documentation from his previous providers. I haven't received that yet. So this is really just to get some guidance on next steps for him. So he's an 11-year-old male, presented to clinic with the mother to establish care. The patient and family moved back to West Virginia from Kentucky back in October of 2018. So he hasn't established with a PCP here in West Virginia since moving back from Kentucky. And I honestly didn't ask how long he lived in Kentucky, but at some point in the past, he had lived in West Virginia previously. The mom states he was homeschooled since moving here, and she does plan to enroll him in public school this year. But with all of his health concerns, I guess is why she had homeschooled him, but looking to put him back into school now. He was previously diagnosed with seizures, bipolar, oppositional defiant disorder, obsessive compulsive disorder, multiple personality disorder, ADHD, autism, intermittent explosive disorder, and schizophrenia. And this is all from the mom. Again, I don't have any documentation or anything from providers. We're working on trying to receive that. But in Kentucky, he was receiving care from the pediatrician. He had a psychiatrist, and he was also seeing a neurologist for his seizures. And I did check, and the mom states that the psychiatrist in Kentucky is continuing to write his medications that he's receiving until he establishes care with a psychiatrist here in West Virginia. His current medications, per the mom, she's given him 25 milligrams of Benadryl, 10 capsules at a time at bedtime, Clonidine, 0.2 milligrams at bedtime, the Proxy ER, 250 milligrams 3 times a day, and the Melatonin, 10 milligrams, 3 capsules at bedtime, and the Quilivant, 12 milliliters daily. I discussed the dosage on the Benadryl and the Melatonin, being excessive. Spoke with her a couple times about this, and she said that she was advised by the previous pediatrician and psychiatrist on the dosage, and that was okay with him. So I've already made the referral for the child psychiatrist into neurology. So I'm still working. I think that I talked to her a couple days ago, and he does have an appointment with the neurologist coming up, but we're still working to get him set up with the psychiatrist.
Awesome. Thank you so much, Heidi.
Uh-huh.
So I'm going to ask first, do any of you have questions about this case?
I'm sorry, you cut out.
Oh, I'm sorry. I was just asking everybody if they had any questions about the case. Everybody out in the tele world.
Okay.
Did Margie and
sorry, this is Tanya. She's our new school-based health provider. Maybe one question I have is just kind of what was the kid's presentation like? What was he like in the room?
Well, in the room, he was moving around constantly, messing with things, touching things, picking things up, putting them down. The mom, when I would ask him to sit down, the mom would then address, what he was doing as far as taking the things for the otoscope. He was pulling a lot of those off and playing with them, trying to get in the trash, getting behind the chair in the room. So very difficult to kind of have him sit still and actually be part of the examination.
Any reports about any kind of specialized education for him in the past, IEP or anything like that?
That's not something that we had discussed, but he does have an appointment coming up in the next couple of weeks, so we can definitely, can get further information as far as his past education and what they've done for him and from that aspect.
Okay. And I assume that you got a release to get his records from Kentucky?
Yes.
Okay. Those haven't come yet, obviously.
No.
Okay. Question. Yes?
Oh, hold on. Let's unmute.
Okay. Can you hear me now?
Yes.
Okay. My question is, that is a long list of diagnoses, and I would be curious if that's more than one psychiatrist or doctor, and that's just been kind of piled on. I think, yeah, I would wonder in the records if that could be kind of like brought down to like one or two or three primary diagnoses. Yeah, I just thought, wow, when I saw that list.
Yeah, I'm going to get to that in a second. I actually thought it was maybe a typo. I also thought that the Benadryl dosage was a typo as well.
Okay, I'm not alone then. Okay.
Yeah, it's kind of stunning. So let me just let me ask one more. What was Mom like when she was in the room with him? How did she interact with him? Did she embellish? How did she describe all this?
Well, one thing I noticed, like I said, was as far as when he was, doing all these things and everywhere, she wasn't really addressing him unless I called attention to what his actions were. So she just kind of was interacting with me and letting him do his own thing, not really interacting with him unless I said something about his behavior, what he was doing.
Okay. So let me go ahead and just start with these diagnoses. And I think the point was made, and it's probably a good one, that if anybody has ever said any of these diagnoses, Mom's just kind of made a mental note of it and dragged all of it along. I cannot fathom that any one provider, even a pediatrician, not to discount a pediatrician, please don't misunderstand, but someone who may have been naive with these diagnoses, I can't conceive that anybody would have given him all of this. I mean, it does not make one bit of sense to me.
Right. Yeah, I agree.
Yeah, I can't wait to see what the psychiatrist actually said, because I can't think even a non-child psychiatrist would have all of this in there. I'm going to go through these diagnoses to kind of just. So he's been diagnosed with seizures. That seems at least legitimate. And he's going to see a neurologist. And of all of his medicines, probably his Depakote ER 250 3 times a day actually seems within normal limits and what you would typically see for treatment of seizures. It sounds like he may have, seizures which are difficult sometimes to manage, which is why he's got the 3 times a day dosing to keep the level up there, is what I'm assuming. That's the one medication that jumps out that seems to be appropriate. And the one diagnosis. So when I start with bipolar disorder, I don't have any idea what the thing would have been that would have given him this diagnosis. Can an 11-year-old have a diagnosis of bipolar disorder? Yes. What would that look like? It certainly could have some severe, significant mood issues. But this may also be something that has been diagnosed incorrectly It's pretty rare in an 11-year-old. Does it happen? Yes. But even in adolescents, we find it to be rare. So in an 11-year-old, was there any family history of a bipolar disorder, or did mom give any explanation as to how that diagnosis came along?
No, there was nothing in the history as far as family history, and she did not elaborate on that. Unfortunately, with this being just the initial visit, I plan to get more history, at the follow-up visit to go a little bit more in detail, since there's so much that we cover and trying to get his vaccinations and everything that he needed for school.
So I'm going to put a huge question mark by bipolar disorder, and quite frankly, until I've got more history, I'm probably not going to go along with many of these diagnoses. The next one is oppositional.
Right.
I know that's just a pattern of negative oppositional behavior. How did he respond when you redirected him from getting into things? Did he respond to you?
He did initially, but then after a little bit, he would go back and continue to pull more things off the wall. And there was a light in the room that he continued to mess with and move around and, moving the chair around and around. So initially for a few minutes, he would listen to what I said, but he would always go back and continue to mess with what I'd asked him to stop.
Okay. And that could be some opposition. It could also be one of these in here is ADHD, and I'm going to go ahead and come to that diagnosis. So a couple of things in there. What may have happened is not so much an oppositional behavior because he kept going back to stuff. It sounds as though he was pretty fidgety and hyperactive in the room, going from thing to thing to thing, and not being able to resist the idea of going back and messing with something again. So it may be that he necessarily wasn't trying to be overtly oppositional, but he was just that, hyperactive. It's again difficult to make that diagnosis, although the description sounds, hyper. But again, you'd need to see that in at least 2 settings. And you'd need to see, does he have all the other criteria that we see with ADHD? When you have just a snapshot picture of that, what you're seeing is hyperactivity. And that in of itself doesn't make the ADHD diagnosis, and it could actually be for a variety of things that we may know nothing about, that the reason he is. I think it's interesting. Mom either just ignores him or feels she has no ability. My guess is that the homeschooling was, I can't even imagine, probably 0, because he's not going to sit still if this is what he's like, and it sounds like she doesn't have the ability to manage his behavior very well either. So again, I'll put ADHD with a question mark. The other thing, and I was looking this up, and I apologize, I forgot to bring it with me. I was looking up because I don't use the Quilivant extended release very often. Did you translate the 12 mLs of the Quilivant to methylphenidate? And I apologize.
No, it was the 12 mLs of the 5 milligrams per milliliter on that, and I'm not familiar with that medication either.
Okay, so if you've got 5 milligrams as the concentration, and he's taking 12, multiply 12 by 5, and what are we up to? 60? Okay, so the reason I mention that is because 60 milligrams of the Quilivant may be inappropriate. The other thing you have to think about when you're using a stimulant with a child, that there's a threshold where you see improvement. And sometimes—
I'm sorry, it's really cutting out. I don't know if anyone else is having trouble with the talk, but I can't. It's kind of cutting in and out with what you're saying.
Let me move the speaker a little bit closer and see if that's better. I apologize. The reason I was asking for the dosage of methylphenidate is that when you're treating ADHD, that you can see improvement with the stimulant up to a point. But if someone is mistaking actual agitation from the stimulant for the hyperactivity with ADHD, they can sometimes continue to increase a dosage, so that at some point what you're seeing is just flat out response to stimulant which if any of us who don't have ADHD took a whole bunch of stimulant, we'd be talking fast, we'd be moving, we'd be distracted, et cetera, et cetera, et cetera. So that can sometimes happen. I don't know in the context of him, was he still hyperactive or was he responding to that dosage of stimulant? I don't really have any idea, but you can't rule that out. And 60 milligrams for an 11-year-old, you know, that may be more than what he needs. It sounds as though he was still moving around, so it's going to have to be looked at either in terms of changing that dose, changing that medicine, because it doesn't sound like he'd be able to sit in a classroom and really participate if he's got that level of hyperactivity. So that would certainly be something. Has she already enrolled him in school? Was she planning?
Not at that point. She had not. So I will contact her soon, and we'll have that discussion and see where she's at in that process.
Right, and it would be helpful to get feedback from whatever teachers he's enrolled with, just to see where he is, because they you know, at this point they're diagnosing him with ADHD. They do have him on a stimulant, and that would be important to know about in terms of the diagnoses. The rest of these diagnoses, obsessive compulsive disorder. There's no description there, so I have no idea whatsoever what that means. For some people, that means genuine obsessive thoughts and compulsive actions. For other people, I will see that diagnosis given to kids who are perseverative. I've seen it given to kids who, you know, he won't quit asking me for something. He'll say, can we go to the store? 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 And people will see that as being, quote, OCD. So I have no idea what the context of this is. Nor, I would add, is he on any medicine for OCD if they did believe he had OCD. So I don't have any idea what to make of that. The next is multiple personality disorder. Okay, whoa. I mean, in my entire professional career of a few years, I have seen 2 what I believe to be dissociative disorders. And I wouldn't necessarily describe but one of them as a multiple personality. And that person actually went on to have a confirmation, I believe, at Johns Hopkins. So to say that is rare is an understatement. To say an 11-year-old has it would be something we're going to have to write up, because it would be phenomenal. When you see disorders like a multiple personality dissociative disorder, that usually occurs, and all the psychologists and therapists in here will know, that usually occurs in the context of trauma. Okay, that's usually where that's going to happen. Now, I'm assuming mom didn't acknowledge any trauma with him at all?
No.
So even in the context of trauma, it would be so highly unusual that I really would like to have you share those medical records when they get there, because I have no idea. I do have parents who will sometimes tell me that they think their child has multiple personality, and that of course translates into, well, one minute they're like this and another minute they're different, and you know, that kind of stuff. So differences, and you know, trying to explain that. I'm going to say I absolutely don't believe that diagnosis without a doubt. I just flat out don't believe it. Don't know where it came from. We'll be interested to see who on earth ever gave that diagnosis. But I would highly, highly doubt that one. Next one is ADHD, and we talked about that. That may actually be true. Next is autism. Did he look autistic to you? Did he have any symptoms that suggested it?
No. No, he interacted with me during the visit. He didn't shy away from any physical contact. No, I didn't see anything that would exhibit that.
So seemed to have pretty much okay eye contact and okay social reciprocity. Okay. You know,
from what I could tell in the initial visit.
So you know what? Often not necessarily a great clinical way to do it, but you get a sense of someone that you're in the room with. You get a sense of a child that you're with, whether or not they've got that barely making eye contact and then looking away, or whether they seem to be socially awkward. You can, just in your initial impression, you're going to get an idea of whether or not you think that something is off. I mean, I think I typically do it without even, going so far. The reason I also asked about an IEP is because I had an adolescent girl on my unit just about a week or so ago, and she had been diagnosed with autism. She didn't have autism. She was low functioning, and she had a low IQ, which made her say kind of bizarre, kind of socially inappropriate things because she'd also not been well socialized, and that sort of thing. But why on earth somebody came up with autism, I will never know, except that I think that's what it was. And she was. I mean, she would just blurt things out and, that kind of stuff, and didn't really know how to handle herself socially. But it was not autism, to the great disappointment of the mother, who was all about it being autism. I, at the first glance, would be holding judgment on any kind of an autism diagnosis. Again, until someone has given me some information otherwise. Next one is intermittent explosive disorder. Okay. It's not even typically a diagnosis we're using with kids. Most of the time people are using disruptive mood dysregulation, but I have no idea what that relates back to. Does that relate back to oppositional behavior? Kids who have autism oftentimes have aggression and unstable mood. If you're going to go with autism, that could be a part of that. You didn't see any evidence of any anger or explosive episodes with you?
No, like I said, when during the visit itself, when I would try to correct his behavior, he, listened for a little while. He didn't, there was no acting out or anything during the visit, so I didn't witness any behavior that would coincide with that.
He may have some temper tantrums. He may have some, issues like that. Did the mom explain why she had enrolled him in school?
You'll have to repeat. I'm sorry. I have to mute everybody so that it comes across properly.
I'm
so
sorry.
Give me 1 second.
Okay. Did mom explain why she hadn't enrolled him in school and kept him homeschooled?
No, she hadn't. At that point, they had been here since October. So I got the impression that she was just late getting everything, doing everything, that she's not really motivated to get him situated because, he's been receiving his medication from the psychiatrist in Kentucky. So I don't think that she was in a real hurry to establish him anywhere and to get him transferred as far as his care with the psychiatrist. So I feel that that's kind of the same thing with the school, but, school started in the last week here. So I will definitely touch base with her and see where she's at with that to make sure.
The reason I asked about the school thing is because sometimes when kids have had real problems in public school, and the parents have gotten calls and they just get sick of dealing with it, that will sometimes cause them to not enroll in new schools when they're supposed to because they just don't want to have to deal with it if there's behavior issues. That could be where some of the oppositional defiant or intermittent explosive idea came from, and I was just curious if she said why, or could be, quite frankly, she's just, sounds like you were giving him a lot of vaccinations he hadn't had. Had he missed a lot?
Well, for his 11-year-old, and again, because he came from Kentucky, I don't have record of, what he had. So for now, I went ahead and did his 11-year-old vaccinations just so he would have that moving forward. And we're trying to get his records from his previous pediatrician to see if you get his complete vaccination list.
I just wondered because sometimes if you've got a parent who's somewhat neglectful of those kinds of things, they'll show up and they're like 3 years behind on their vaccinations, and I just wondered if that was the case with him. Okay, so we're going to put a hold on intermittent explosive, and then next would be schizophrenia. Again, incredibly rare in a child. Have no idea what the basis of that would be. Highly doubt that is a diagnosis. And I cannot fathom in any way, shape, or form that all of this mess could all exist at the same time. So I think you're right. She's gotten little snippets of things that she's heard, or maybe she's decided, and the DSM-5 is on the internet, so people can get on there and diagnose themselves and others, and sometimes do. So I would put probably a big X through schizophrenia. Would be incredibly rare to see that. So what I would say at this is I would say probably a presumptive diagnosis of ADHD, perhaps a diagnosis of oppositional defiant. That's as far as I'm willing to go based upon this limited amount of information. And we'll find out more. I do hope that you'll bring this case back to our the echo, because I'm really curious as to what you find out. Now, the next troubling thing, which is troubling, is the medications. So let me start with Benadryl. 10 of those at bedtime. I see here that the first thing you said was way too much Benadryl. I absolutely agree. Cannot fathom that a pediatrician or a psychiatrist would recommend that dosage. And did you think she was going to actually cut back on it, or?
Yes, I think that she's going to work on cutting back on that in the meantime, but I asked her a couple times to clarify that. I'm like, did I hear this dosage correctly? I mean, that's, obscene amount. But she confirmed, so.
Okay. Well, I definitely, again, would have recommended tapering that back, and get him on, if they're going to keep him on Benadryl, 25, 50 at the most, would have been my recommendation. The next is Clonidine, 0.2 at bedtime. So now, in addition to this Benadryl, they're going to put Clonidine on top of it. How was his blood pressure in your office? Is Dr. Giddens?
(133/64). He wasn't hypotensive. He was a little bit, for his age, it was a little bit high actually. But he wasn't hypotensive.
Well, I think for now, I would say leave the Clonidine alone. You've got her coming, that's not an unreasonable dosage, and you've got her coming off the Benadryl with him. So I would go ahead and leave the Clonidine as long as his vitals are okay. I would leave that alone, assuming he's got some kind of sleep problems. The next one is his Depakote, which is going to be managed, I'm assuming, by the neurologist. So I wouldn't bother that. And then the last one is the melatonin, or not, second to last is melatonin. And that's 30 milligrams. I don't have any idea why anybody would recommend that. I don't think that there's any evidence of anything above 10 milligrams. That's the most that I've ever prescribed for a child or an adult. And again, you got that on top of Benadryl. That just can't be good. Did she agree to reduce the melatonin as well?
Well, we'll talk about that. I'll give her a call and we'll discuss the melatonin too. Yeah.
I would certainly reduce it back to 10. And, once you get the records and you go through them and you think, wow, this kid's really got a sleeping problem, then he may need a sleep study. I mean, I don't have any idea, but certainly his medications, currently are not healthy, not indicated, would not be approved for anybody, quite frankly, much less an 11-year-old. The last one is his Quilivant, and you said it's the 60 milligrams. That doesn't seem to be an unreasonable dosage of methylphenidate, extended release. He's getting that through the day. So that's, for now, have him in a hold pattern until you get some records back. That's not out of the realm of possible, because an 11-year-old is going to metabolize medications like that pretty quickly. So that may be an appropriate dosage. So that would be my take on this child and his medications, which it sounds like we're going down that road.
Okay. Thank you.
Okay, yeah, appreciate it if you'd follow back up with it.
Yes, definitely. Make sure we have those records and bring back around once and also we get them established with the psychiatrist too.
Sure. Anybody else with any thoughts?
We do have a couple of people using the chat feature, which is great. So we just had a couple of people bring up questions that I just wanted to address. The diagnosis, please correct me if I'm wrong. All of the diagnoses were reported by the mother, right? Because we don't have the chart from past anybody.
It's all from the mother. Unfortunately, they didn't bring any records with them to the initial appointment. And, we're in the process of requesting them, but I have not received anything yet from the pediatrician, the psychiatrist, or the neurologist.
Right. Yeah, so that's where all of that came from. And then let's see, there was a couple people asking about untreated intellectual disabilities and how homeschooling factors into that. And then also questioning, or would it be useful to question Munchausen by proxy?
So let me speak to the first about the intellectual disability. I actually questioned, possibly that could be a contributing factor to some of the behavioral things. I'm not aware of a typical homeschooling program that is going to offer what intellectual disability children typically through an IEP are going to get in a public school system.
Yes, you can, let's unmute you real quick.
Okay, thank you. And that was my question. I'm wondering if this child maybe was started in school in special education and then taken out of school and kind of, it just seems like, just my impression is maybe some type of cognitive disability with no management of all those behaviors that can accompany, and just latching on to a lot of different diagnoses. So it would really be beneficial for this child to be enrolled in school and, have that proper testing done to see, if that could be, one of the primary things going on here.
Well, yeah, I think I'd mentioned a little bit ago that he very well could have, intellectual problems. He could have also had some behavioral issues that the mom didn't want to have to fool with when the school was calling or asking her to go do something, or therapy. So there's a couple of different things, and I think it will be helpful to get feedback from the school when he does get into, if in fact she enrolls him in public school. Those are really good. The last question had to do with Munchausen's by proxy, and that actually had gone through my head, and it went out of my head when I got ready to mention that. Munchausen is certainly something that she could have if she is going to have all of these diagnoses. And we do see parents who come up with different diagnoses. Bipolar is certainly one that comes up a lot, that parents will come in with, and they do it for a variety of reasons. Sometimes it is to go from doctor to doctor to doctor. And sometimes it's, aimed at getting medication. ADHD is another one that will get added on. Certainly all of these, it will be interesting to see where all of these things, came from, and what exactly the medical records reflect. But yeah, Munchausen's is something that you wouldn't rule out. I mean, typically they present with more physical issues, but psychiatric issues would be completely within the realm of possible, and I couldn't rule that out either.
Excellent. Heidi, thank you so much again. I know that everybody probably does have more questions, so you are welcome to chat those or email them, and we'll continue to address everything. And Heidi, we'd love to see this person back whenever you see them back. So we are going to go into Dr. Goody-Kuntz's didactic. We have, I think, just enough time. And do you want to tell them kind of how you decided to?
So I was asked to do a didactic on prescribing medication for children and adolescents. And that topic is so huge that, that encompasses a full year for residents to even learn about that. So what I thought I'd do is I'm going to break it up. And one week I'm going to do a didactic, and then another week Amanda's going to do one on some type of, therapy issues. And so I'm going to break it down and do different diagnoses to kind of make sure that I cover some of the things that you want. And any questions you have that I don't answer, then I'll be glad to go back and get some answers for you. But I thought that way we could get different groups of medicine and maybe talk about them a little more thoroughly than just kind of a quick in and out. So you all have, do they have a copy? Can they see the slides?
They'll see the slides. They don't
Okay.
have a copy yet.
All right. So I'm going to go ahead and start. And if any of you all want to get copies of these, you can for some of the prescribing information. So the first thing is that I started off with is, and this sounds, you know, maybe kind of silly, but it's true. The overview, first of all, is for unipolar depression. And the reason we're talking about unipolar as opposed to some type of bipolar illness, which we will talk about at a different time. But these are typically people who go from baseline to depressed, then back up to a baseline, and then depressed, either in a single episode or recurrently. So that's what we're talking about today. So children really began being treated for depression in the 1960s. For the longest time, psychiatry did not recognize children having depression along with most other illnesses. And so finally people realized, yes, there's criteria. It doesn't necessarily look like adult depression, but they do have it, and we should be treating it. So the initial treatment in the 1960s was with the old tricyclic antidepressants, Elavil, and some of those kinds of medications. They formed the basis, however, of safety so that the FDA went on to have other randomized trials. So when those were established for treatment, the FDA allowed them to be used, the tricyclics, because they've been used for depression for a long time. But then in the 70s, when the newer medications came along, and by that I mean the serotonin, selective reuptake inhibitors, when those came along, then companies who brought those out to market, for example, fluoxetine, then they went ahead and invested money in doing the randomized trials that the FDA was going to require in order for them to approve them for the use of kids. So they had a precedent. They knew that people in the psychiatric community, more likely them than anybody else, were actually going to treat kids. So they wanted to make sure that the FDA was going to give an approval for that. So that's, you know, so those future randomized trials, they were the basis of that was for the 60s. The FDA requires two things for drugs to be approved for treatment of anybody, truthfully. One is for it to be safe, and the second is for it to work, basically. And lots of medications can prove to be safe, but as you'll see in just a minute when we talk a little bit about it, not all of them work. And the FDA has pretty stringent guidelines that those studies have to show that they make a difference. In other words, that they actually work. And that's why you'll see there's so few of them. So what we do is we're going to look at what the criteria is to treat children acutely, and then continuant, and then do maintenance and medications for all three of those. Okay, so diagnosis for appropriate for treatment. So it seems like it should be obvious, but the things that I want to include in here are the things that we treat children and adolescents for with depression. We treat major depression, which has its own specific criteria in the DSM, and that's changes in appetite, duration of more than 2 weeks. I'm not going to repeat all that for you, but major depression is certainly an indication for treatment. The second one is dysthymia, and that is where you've got that persistent depressive symptoms. Day after day after day, they have low mood, low motivation. Either they don't want to eat or they want to eat all the time. You know, these are the kids who want to just sit and play video games and don't really want to interact and don't want to do much else. These medications are also approved to treat dysthymia. And, you know, people for a longest time thought, well, dysthymia is not really major depression, so we really shouldn't treat it. Actually, I think a lot of kids have dysthymia. They come in with that chronic low mood, and you can also use these medications to treat that. The next one is they don't meet the criteria. This is sort of that otherwise kind of category. They have some of the symptoms of depression, but they don't necessarily need all of it, but they do have, on the symptoms they have significant functional impairment. Okay, motivation is so low, they don't get out of bed, they don't do anything, and so they don't go to school, or they don't get any exercise, or they eat all the time. They've got some of the symptoms, not enough to make that major depression, but they've got a lot of functional impairment, so we treat that. The next category are the ones who have other diagnoses that can be treated with antidepressants. So we've got a kid who's got some depression a little bit, but their major problem is anxiety. So we go ahead and treat anxiety, but we're also picking up some of the depression as well. Because not all kids who have depression have anxiety, but when you have a child that really has terrible anxiety, they're going to eventually have depression along with it because of all the limitations and the stress that it causes. And then the last category are the kids that have come in and you've not been ready to put them on medicine, but you sent them for therapy. And then, 3 months, 6 months later, somebody says, you know what, they're still not any better. We've been doing all this therapy, but there's clearly something that's chemical, biochemical with them, and medication is the next category we need to go to. So those are some of the groups that are appropriate to treat with antidepressants. So the general approach is to remember that it's important to confirm that this is actual depression. The second thing is that these are not medicines that you give on an emergency basis. I know that sounds kind of silly, but it's true. I will, from time to time, admit an adolescent to my inpatient unit or a child to a child unit down in Clarksburg at Highland. And I will have an insurance company. I actually had this happen once. I had an adolescent that had gotten to the unit at noon. And at 1 o'clock, the insurance company called to ask me what antidepressant I was going to start them on. Okay. These are not medicines that you're going to get a result from in the next 24 hours. So taking some time to think about, is this an appropriate use of medicine and what the medicine should be? We're not given these in an emergency situation. This is not something that is a life-threatening instance for that particular kind of medicine. Now, suicidal thoughts, yes, that's emergent, okay? And you have to manage when you have a suicidal child or adolescent. But medications like antidepressants are not part of the management of somebody who has suicidal thoughts. That has to do with safety and being able to monitor them and look at those things. At some point, you'll decide that yes, an antidepressant is appropriate or not, or that they're on one and it needs to be changed or not. I would say with some regularity, I have kids who come in who have had a suicide attempt by overdose or have cut themselves. There's a chance that when we look at all of the social stressors, that this was prompted by those things. And they don't really meet criteria for major depression at all. Once the social stressor or whatever it is that's happened has faded or, in the background and you've done some other things, they may leave on no antidepressant at all because it's not indicated. And sometimes they come in and the first thing somebody will say is their meds need to be changed because, clearly they're not doing well. Well, maybe they do and maybe they don't. So it's not an automatic thing that you're switching and changing and starting and stopping medication. The things that people need to keep in mind are that once you start somebody on medicine, prior to that, you need to discuss with the adolescent, if they're, assuming they're of an age, and the parent or guardian, what the benefits are going to be, what the concerns are going to be, and the alternatives if you don't prescribe medication, what the side effects are going to be, what the consequences are going to be. All of those things need to be discussed ahead of time. The other thing to consider is most people, even our own residents here at Chestnut Ridge, they'll start an adolescent on an antidepressant, and I'll ask them when they're going to see them back. And they'll say, with some regularity, well, my schedule's really full, so I'm going to see them back in about 6 to 8 weeks. And they are very unhappy when I tell them, absolutely not. You cannot start somebody on an adolescent on an antidepressant. If you think that they are seriously depressed enough that you're going to start a medicine, then that means you seriously need to see them back. If you look at the recommendations from the American Academy of Child and Adolescent Psychiatrists, they recommend that you see a child after starting on antidepressants at least on a weekly basis for the first 4 to 6 weeks. The longest that you typically are supposed to go is 2 weeks. So, that's something to keep in mind, because many people in their schedules don't have the ability to see people back that quickly. Okay. So, in order to look at these things, you need to provide education. You need to do a pre-treatment evaluation. That means that, and it's for those of you in primary care, we don't typically do this as much in psychiatry. We actually will have the pediatricians work with us. But even doing a physical, we look at things. We look at their thyroid. We look for signs of abuse. That pre-treatment evaluation involves all sorts of basic things that you would do in a physical exam of a child. The next 3 things are, and you can go to the next slide, are medications. Okay, let's assume that you've decided meets all your criteria and you're going to start them, okay? So these are the guidelines, and those are the ones we continue. First is fluoxetine, that's Prozac, okay? If you're going to use Prozac, which is approved by the FDA to treat children and adolescents with depression, the starting dose for children is 5 milligrams. You do that for 3 weeks, and then you titrate them up to 10. If there's a partial response and no real side effects, then go up to 20. It's interesting because I have had insurance companies, Rational Drug Therapy being a perfect example, they don't want me to start a child on 5 milligrams. They'll argue with me about it. And I'll explain, this is a child, I've been known to start them on 2.5 milligrams of the liquid form of Prozac, because I'm not necessarily trying to target an improvement or a relief in depression at that point. What I want to do is get medication into that child, and I want there not to be side effects. I don't want this to be frightening. If I start at a really high dose, number one, it's going to really intensify any side effect they have. And then once they've had something like that happen, particularly if parents are already reluctant or the child's reluctant, then I have totally lost the rapport that I wanted to establish with that child and that parent. So 5 milligrams for at least 3 weeks, go to 10, and then you can possibly go up to 20. For adolescents, you start at 10, you go up to 20. If you get a partial response, you go to 40. If there's some, again, partial response, you go up to 60. Those are the guidelines that I use, and I think are pretty well recognized as being appropriate for fluoxetine, which is Prozac. Okay. The next one is citalopram. Children and adolescents are dosed the same for citalopram. So it's an initial dose of 10 for a week, increased to 20. If there's insufficient, you can go up to 40. If it's still some insufficient, but it's tolerated, you can go up to 60. Now, going up to 60 milligrams from 40 of citalopram means that you run the risk of a QT prolongation, okay? If you're getting some benefit, or the parents say, you know what, we see a little bit of improvement, but then it kind of fades away and there's no side effects, you may decide to get a baseline EKG at 40 and then go up to 60, and then after a week get another EKG. I don't think there's any indication to go above 60 milligrams in an adolescent. And there's no demonstration that going above 20 in a child is indicated. So that is citalopram. The next is escitalopram, which is Lexapro. This is the other one approved by the FDA to treat children and adolescents with depression. Again, dosage for both adolescents and children is starting at 5 milligrams. Why do we start so low with that, with Lexapro? Well, for me, what I've noticed with Lexapro, and other people would argue that's not, they don't see it, but what I have seen is some activation with Lexapro. Sometimes they will get more jittery, more anxious. So sometimes I will give Lexapro in the morning to start. There are some people that say, nope, makes me sleepy, and we give it at nighttime. But the dosage with escitalopram is usually lower. And again, as you can see on the slide, we start at 5, go up to 10. After 3 weeks, we can go up to 20. Now, there is not a lot of literature that suggests that Lexapro above 20 really does anything. But there are some people who anecdotally have said, you know what, when I got to 30, I saw a difference. So again, you may get some QT prolongation. So get an EKG at 20 milligrams if you're planning on going to 30. And after they've been on 30 for a week, get a repeat. There is no indication whatsoever for any dosage of 40 milligrams of Lexapro. Sertraline is Zoloft, 25 milligrams for a week, then increase it to 50. Continue that for 3 weeks. If it's inadequate, then increase to 100. If you get a partial response after 4 weeks, increase it to 200. Paroxetine, that's Paxil. It's not indicated in pediatric population. I see it used all the time. There were some studies that were done in Great Britain that looked at increased suicidal actions by adolescents. The two medications that they identified as being most closely associated with that were Paxil and Effexor. I don't think either one are first-line treatment. I absolutely don't think Paxil is. It causes a lot of weight gain. It causes a lot of problems. And when I talk about discontinuation in a minute, it's one of the worst offenders. So I see kids come in all the time on Paxil. I wouldn't recommend it. I don't think there's a good indication for it. Okay, monitoring. What are you going to look for? Their moods are worse. So the first thing when you get ready to start this medicine, you want to find out what their mood is at baseline. Are they suicidal? Are they not suicidal? So you want to know that, so for comparison, and you want the parents to know what to look for. Are they more agitated on the medicine, Lexapro or some of the others? Does it seem to aggravate them? Are they more irritable? This could be that you've got a mood problem, and I'm going to talk about mood disorders in medicine, and you've aggravated that, which goes into the next one, which is hypomania or manic symptoms. Do they seem like they have just gone straight up? Appetite disturbance and sleep disturbance. Some of these are manageable by dosage adjustments, but some of them are indication that this medicine is not going to work. If the side effects are minimal, you can sometimes stick it out, but sometimes they're not. In addition to appetite disturbance, you also get GI stuff and stomach nausea and things like that. And you can determine whether or not you think it's manageable or not. Discontinuation, when to discontinue and how to do it. Discontinuation can happen for a number of reasons. If somebody breaks out in a rash from head to toe on Prozac, you're going to stop it immediately. For other times, if you've decided, okay, this medicine isn't going to work and we need to taper off and do something else, or you've reached 1 full year of them being on an antidepressant medicine, they're doing great and they'd really like to come off, then you can also do it. Tapering is best, tapering with 25 to 50% of the total dosage per week until they're off of it. And of course, as I said, if there's any compelling reasons, you can go ahead and stop it quicker. Prozac, fluoxetine is less likely for any of the discontinuation syndromes because, and quite frankly, I don't really taper Prozac unless it's up at like 40 milligrams because it has a long half-life. If I stop Prozac today, a month from now, there'll probably still be a little Prozac. It tapers itself. So that's why typically with Prozac, we don't oftentimes do a taper of it. But if they're on 40, you can take it down to 20 for a week if you want to and then stop it. But ordinarily, it'll just gradually taper itself out of there. And that was the last slide I had on that. Now, what I didn't mention, I've got 2 seconds I'm going to tell you. I did not discuss with you Effexor, Cymbalta, Wellbutrin, or any of those. None of them have FDA approval for treatment in kids, okay? And that's because of a lack of efficacy, or quite frankly, the companies who made them decided we're not going to put and invest money in randomized studies that are going to allow these to be used and approved by the FDA. I can talk more about those if you'd like in the next time, because I'm going to talk about anxiety disorders as well. Do we use them in kids? Sometimes we do. We actually do. It is an off-label use. And anytime you're going to use an off-label use, you need to have some clear idea why you're choosing that medicine. Sometimes it's because mom did great on Effexor and grandma did great on Effexor. So, okay, we're going to give them a little bit of Effexor. but there need to be some clear indications about that. There's also some testing that has to do with the genome testing that's going to indicate which medicines work and which ones don't. And sometimes you'll get a list, and Effexor and Cymbalta will be on that list. Again, you have to clearly identify why you're doing it and set up what you're monitoring for and be real clear. Off-label use medications are probably the ones you're really going to want to bring back the quickest and really be monitoring the most carefully.
Awesome. We are out of time. I did want to just ask one question that Dr. Seibold had. Do you recommend PHQ-9 testing before meds and monitoring progress?
Sure. That's another way to do it. We also use a RADS, which is a Reynolds Adolescent Depression Scale. There's also one that's called KSADS. I think there's like a kitty one. Whatever you use and are comfortable with and has given good reliance for you, you can get those serially over time to give you yet another way to measure what the improvement has been as well. Although, in my opinion, that's something you use. There's no substitute for your good clinical judgment. You know, you're in there with that person, and you know, if you can establish good rapport, hopefully that's gonna give you some. But the other thing, the testing, the PHQ-9, those things, they're not without value, because sometimes if you ask a kid a direct question, they'll minimize it or say no. But in a questionnaire, you may get a more honest response. So it does have value. There's no doubt about that.
Excellent. I'm sorry we're out of time, you guys, but definitely email me your questions and I'll make sure they get to Dr. Goody-Kuntz.
Sure.
We'll see you guys in 2 weeks, and Amanda is going to do her pediatric irritability therapeutic didactic that she had talked about. But thank you all. See you later.
Thank you.
Thank you so much. Sure.